Good morning, everyone.
Hello. Good morning.
Hey,
Hello, good morning.
good morning, Sana. Are you going to present?
Yes.
Nice. Yeah.
Hi.
Hey, Thiru.
Hey, welcome everyone.
What's in
Thank
the
you.
background?
Hi, sir. Good
Yeah,
evening.
that's the Corporation of Chennai building, Ripon building.
Okay.
So that is the one of the oldest corporations in the world.
Yeah.
So
Nice.
and it's named after Ripon,
Lord
Lord
Ripon.
Ripon. Yes. And there is an interesting connection with this. Um, the first governor was Elihu Ale. Ale was from Boston, so he was the
Oh,
he
yeah.
was the
Yale
first
University.
Yale University. So
He made
he
all the
was the
money
first governor. He amassed the
Uh-huh.
wealth from Chennai and went on to start Yale University. So that was a very interesting story because he was convicted of corruption here in this corporation in Chennai.
Uh-huh.
And then he was, he went back to Boston and donated a lot of money for some missionary college in Yale. And
Mhm.
yeah, so then the university was named after him.
Good. Yep.
So that is Chennai US connection.
Yep.
So I think what's time there now when
9 a.m.
yeah.
Just wait for a minute for Nikila. I'll text her. Maybe
Ah.
she was doing Garba last night, so
Oh really?
yeah.
There was some celebration or something?
Oh, Navratri Garba goes on, no?
Yeah. So
Christina,
you're
I'll text Christina and Cathy Turk as well.
yeah.
I think we can get started while they can join it.
Yeah, I'm not sure that they'll be able to join in, but we can definitely text to see.
Oh, they're not joining? It's just us?
I think it's just us.
Okay. Oh, that's fine then. I was
Yeah.
thinking it was them as well, but yeah.
Maybe you'll wait
That's fine.
for
We can
1 or
get
2 minutes so that people can join.
Yeah.
So then maybe 1 or 2 minutes and then we'll start. So
This is the last one, right?
yeah, this is the last one. Yeah.
What's the
So
feedback? Did people like it?
yeah, exactly. Everybody liked it, and some of the lectures, some people couldn't attend, they missed it. So anyway, we have recorded everything. We will
Right.
compile everything after this talk, and then we'll put it in the website, so they can watch all these things again. So now, what Sahana, you want to start with the first case or?
No, sir. I mean,
Yeah, you okay? Yeah, I'll ask Vivek to start the case first, and then we will have Alifia. She'll have 2 cases, and then you can do the 4th case.
Yes,
Vivek,
sir.
are you ready?
Yes, sir. I'm audible.
Yeah, you're audible. Can you share your screen?
Yeah, one second, sir. I think it's visible, sir.
Yes, right.
Yes.
Yeah, it's visible. Maybe we'll wait for 1 or 2 minutes and then we'll start.
Yeah. Okay.
Vivek, whenever you're presenting, tell us your background as well.
Yeah. Okay, sir. So background.
Yeah.
I
Yeah, so this is Dr. Vivek Balaji is my fellow. So he's with us for the past 6 months or so. He's going to be here for 6 more months as fellow. So he's going to present one of the cases we had recently, and we had difficulty in diagnosing and managing. So we thought that that is the right case for us to start today, so that we'll get some input from the experts, and then we'll go ahead with the further management of the case.
Sure.
So shall we start now?
Yep.
Okay. Welcome all of you. So it's been a incredible learning for us for the past 6 months or so. So we have completed 5 lectures on pediatric swallowing so far. From the start, like, basics of feeding in infants, and then swallowing, bedside evaluations, instrumental evaluations, and some of the case scenarios, and therapy and surgical management, everything we have discussed so far. So we have come to the fag end of the program. This is the last program. And here we are going to present some of the cases, mostly from India. And we will see, how these patients can be evaluated, and how we can improve our management strategies. So we will get input from experts from Houston Children's. They've been kind enough to do this program and also guide us all the way. The team headed by Dr. Deepak, and I think Nicola Roll is joined, or she's going to join, and with all the SLP team of Dr. Deepak from Houston. So here we are going to start our first case. My fellow Dr. Vivek Balaji is going to present the first case. Right, here we go.
so
Over to you, Balaji.
so hi all. So hope you're all having a good day. You're going to have a good day, or you had a good day, since we are all in different time zones. So it's time to feed our brains with some dilemmatic situations here. So this, as Dr. Thiru said, this was one intriguing case for us, which we had encountered very recently. So it was just a 2-month-old child. So this is the history. So this is a 2-month-old child. It was brought to our clinic with complaints of delay in swallowing. So it has been there for on and off for just 1 month. It was just a 2-month-old child. The parents, they typically gave a history that the child holds up the feed in its mouth for a long time and then swallows it with an audible sound. When the child, when the parents came to our clinic, they didn't have a video recording of it. But when we discharged home, they just sent a recording of that video. I'll just show it in the next slide. So she said that she heard a kind of a different sound. Other than that, the child did not have any symptoms. There was no breath holding spells. There was no cyanotic episodes, or no other red flag signs was there. So regarding the perinatal history, the child was born as a preterm because of premature rupture of membranes via normal vaginal delivery. It weighed around 1.45 kg at birth. So the child was kept in NICU for 7 days regarding the birth-related issues. And during the stay in the NICU, the child was fed on NG tube feeds with express breast milk and formula milk. and then was switched over to Palladai fields. And Palladai is the one in the right now. That's the image for someone who hasn't encountered that. That's a kind of a small feeding vessel, which it is given to newborns here. I don't know if it is followed in the rest of the world. So the child had no complaints till he was fed on Palladai. Then the child was started on bottle feeds after 1 month, following which she started developing such symptoms. All this while, the mother hadn't directly breastfed the child, stating that she hadn't enough milk, so she had been feeding the child via a bottle with express breast feeds and formula milk occasionally. So the child had a good weight gain and weighs around 3.5 kg as of this month. So the next one is the typical video. I want all of you to to switch on your speakers so that you can hear that sound. Maybe that will give a clue. So this is it. Just I hope sound is audible. You can see it just now. Just notice. That one, that kind of sound. That was like a kind of a burp. So that was the typical sound she said. This she sent after she went home after we evaluated her. So we got this video just a day back. And then the other systemic examinations were normal. General system was normal. The child was admitted under our GI consultant. So he had ordered for a barium swallow to look if there is any structural defects or something. And the barium swallow. Sorry, what happened to the barium swallow? One sec. So the barium swallow isn't visible for you guys. Why? So I'll just show you the barium swallow next. So it showed features of aspiration. So, but after the barium swallow, the child did not show any symptoms or features of aspiration. The child did not deteriorate. It was just normal. So we thought we'll have a look via endoscope what is happening in real time. So we subjected an airway endoscopy and OGD at the same time. So on airway endoscopy, we couldn't pick up any significant findings. There's only a mild pharyngomalacia and laryngomalacia. And this did not correlate with the patient's symptoms. On OGD also, there was no significant finding, just that the GI consultant reported as mild gastroesophageal reflux. So this is the endoscopy picture video where we had examined whether we could find any structural defects or any H-type fistula or something, but we couldn't pick up any significant positive finding. We had gone all the way up to the carina to look if there are anything abnormal, but nothing showed up. So we were like back to square one again, like what was causing the patient symptom or what are we dealing with? So then, okay, we thought we'll have a look at the hypopharynx. That also didn't show any mass or obstructive lesions or anything. So we thought maybe if there is any submucosal laryngeal cleft or something. So we tried to probe, and the probing also did not show any significant finding. It was just normal finding. So we were again like thinking what is causing the problem. So we had asked the GI team. They also did an OGD right thereafter, and this was the OGD picture. This also did not demonstrate any significant finding. He just reported it as mild gastroesophageal reflux, and just symptomatic treatment was started for the same. So we had thought, okay, maybe we'll try functional endoscopic evaluation of swallow. So in a 2-month-old child, it was quite difficult. So we proceeded with it. We had sought the assistance of our swallow pathologist. She had prepared a colored bolus. So all this while, when the child was admitted, the child was fed on NG tube. So while evaluating, we had removed the NG tube, and then we had given a colored milk. The milk was coated with pista so that we could have whether if there is any airway invasion or penetration. But even everything was normal. You could see that the milk is just correctly guided into the hypopharynx, and the swallow protection, the airway protection is is quite good. And this also seemed to be normal. We had observed close to around 10 to 15 minutes probably. This is just a edited video where I had to edit it for 1 hour. So this also didn't demonstrate any any clue so that we could get some diagnosis out of it, because the parent gave the history that she could hear that sound, the sound which I showed previously. And barium swallow also showed aspiration. But so we thought, okay, this also didn't demonstrate anything. Maybe we'll have a relook again. So this was the piece report generated by our swallow pathologist. We said that everything was fine. Oral feeding is currently safe. So anatomically, functionally look normal in fees. So we thought, okay, the next step is maybe we'll have we'll have a look with video fluoroscopic swallow study. So we had subjected the child to a VFSS study. So that also didn't demonstrate no anything no specific. So this is the VFSS clip which we had recorded. There you can see the barium mixed milk just nicely getting into the esophagus from the oral cavity. There was no signs of penetration, aspiration, anything. And we were again back to square one. Like, no. So what is the child undergoing? Like, what is happening inside the child? Why is it causing that problem? Because the parents reports that that was something abnormal. So we had to take that significantly. But all our examinations were like negative. It didn't pick up anything. So you can see there was this. Our swallow pathologist thought that there's only a mild stasis in the esophagus. That also couldn't contribute to the symptom. Like so, we had been thinking like, was there any trichopharyngeal achalasia, which can be a congenital condition, but it had to happen every time. But the parents report that it happens only occasionally. Even after all these interventions, we had observed the child in the ward, and during the stay in the ward also, the child did not have any problems. It fed nicely, it had good sleep, it was normal, the physical activity was good. And the swallow pathologist from our team, she noted the concerns that the caregiver reports potential stress during feeding interactions, which means that they are finding it difficult to feed the child, which they feel something is abnormal. So we thought, okay, now we'll bring it to the international forum so that you can also opine like what could be the problem in this child.
Hi, sorry, I have just a few questions. Can I ask a few just to clarify some things? Okay, so that swallow study that was just done, was that done with a syringe or was that done with the actual like cup that the child was drinking from?
The child, so I was the one who did the swallow study.
Okay.
So the child has not yet trained in bottle feeds and was not comfortable with bottle feeds. She was comfortable more on Pala dye feeds. But I didn't have Pala dye at that time, so I did with syringe.
Yeah.
Especially the Philips event, the mom reports that there is an increased time and efficiency. And she's also saying that in Neo-Eat, the mother reported that there is an increased time and stressful feeding time. And also when I scored Neo-Eat, I could see there was an high concern areas on the energy and physiological domains. So right now, what we have done is we have discharged the child asked them to come after 2 weeks follow-up. Now, there are two things that we have said the mother. So one is I have went ahead and taught the mothers on disengagement cues and stress signals. And we've set strict bottle feeds with Philips Avent and not the Love. We have another brand, Love Lab, which has a free-flowing one.
Yeah, அவங்க சொல்லட்டும் அதுக்கப்புறமா என்னன்னு சொல்ல நம்ம பிளான்.
So should I?
Yeah.
Oh, okay. I think she muted now. One thing that just sticks out, and I know you were saying the syringe was kind of the best thing for that moment, right?
Yes.
It's tough though because the swallow coordination and physiology might look a little different when you do the bottle and the cup versus the syringe. I found that too with children, that it's not like the best representation of their swallow and swallow physiology because it's not the actual drinking vessel. So, and I know I've had to do it too. Like sometimes you just have to do what you have to do. But if you can, I would try using the actual drinking vessels just so you can have a better assessment of that.
Yeah. So
yeah.
Initially, when I did a previous clinical bedside evaluation, so I could see, I mean, that's what I've written in oral phase. It was atypical because I couldn't see an observed latch or observed tongue coordination. But
Mhm.
however, the swallowing pattern was there. Like I could see approximation in the VFSs, you could see approximation of base of tongue with posterior pharyngeal wall. So though there was this atypical pattern, the swallowing
Mhm.
aspect, swallowing was safe.
Yeah.
However, she was not able to drink easily with bottle.
Yeah, and it's interesting because I think some of the things you're describing, like the gulping and the holding in the mouth, we see this a lot with kids who either they're having a hard time, like it might have been functional or oral phase, right? But the coordination's just a little off. So sometimes they will purposefully hold things in their mouth as a way to coordinate and kind of get ready before they swallow. If it's too much or it's a way they're actually trying to compensate at times, we will see that. And then when you hear that audible swallowing, that can also mean like it was a little bit too much, the bolus was too big, or they're just having trouble controlling that a little bit. Like I see that a lot with my kids where they get way too big of a bolus, they swallow and you hear that like that audible swallowing. And then so those are two things that come to mind. And what's interesting, you know, this baby was a 34-weeker, right? So when you look at this baby, you're saying they came at 2 months, right? Really, if go by their adjusted age, right? They're more like a month or a little bit under a month even. So this baby's coordination, I feel they're kind of still trying to figure it out. It sounds like, you know, and you'll see the bolus holding and the audible swallowing. And it sounds like this child had just some, even though it was functional, things can be functional, right? But the coordination just isn't quite right in their oral phase too, which can affect the pharyngeal phase as well, if that makes sense. And especially when they're delatching and saying what you were saying, they don't have a good latch, they're pulling on and off. They just don't ever get settled and get to really latch to the bottle, get that nice latch and get those oral phase skills really like nice and and rhythmical and good.
Yes.
And I think that can, the oral phase can really affect the pharyngeal phase, which is what I think you were hearing with the audible gulping, things like that. It sounds like this baby, really, I think you were doing a lot of good interventions with like having mom looking at the cues, things like that. Sounds like maybe the baby needed maybe even a slower flow rate, maybe even more pacing, maybe some positional changes. Just from that video, baby was kind of back a little bit. Maybe we could have done more like swaddled elevated side lying. Like, so think about positioning, flow rate, pacing the baby, like really starting with a lot of external support and then gradually fading that support. And it would have been interesting to see. And did you say you noticed the audible gulping with the cup, the little cup more than the bottle? Was that it? Did I get that right? Or was it with the bottle?
She's not been trained with the bottle, only with
Right.
cup. So in cup, yes.
So I'm wondering too, because the cup, that's a different motor, those are different motor patterns than with the bottle too. And I find the cup it takes a little bit more skill, I think, you know, from a oral motor perspective too, to drink from the cup. I think this baby was just,
Excuse me, Lauren.
yeah,
This is you know what they're doing here is something called palade. Palade means
yes,
something like
yes.
yeah, you know what is palade?
Yes, yep. And I saw
We-
that picture was a really good picture that I saw.
Yeah.
That was great. I love that you had the picture because I could
That's
see what it
helpful.
was. And I
Yeah,
actually
yeah.
like that. I like the little
Yeah, you know,
narrowing of that.
that is a
Yeah,
routine thing for every
yeah.
mother here in this
Uh-huh.
part of the world. They use
Right.
this for feeding the child. Yeah.
So maybe we could use that, but teach them. And I liked how there was kind of like it was a little bit more narrow and almost like little funnel on the to do smaller boluses, change their positioning, right? And really, I think, and I couldn't see very well in the video. I'm sorry, I just couldn't see, but I didn't know if they were kind of pouring versus one versus like a half tilt. You know, you could play around with things like that and really see if it changes that audible swallowing or you hear that. Look at bolus size, look at how much you're giving the child, like that type of thing with positioning. Maybe some jaw support to help them, things like that. Just to
So
see.
I have a doubt. So do you try all this while you do swallow study or after, like
Good
now that
question.
we have found out that swallowing is safe, because that's what we tried doing. Basically,
Right.
okay, the swallowing physiology is atypical, so that's what Sahana was coming to. Like the next 2 weeks,
Sure.
we are training the parent and making them more cue based, less volume driven, and So we do
Yes.
that in 2 weeks, and then maybe systematically desensitize the tube feeding. So is that the right method? Is that the method that you follow as well? Yeah.
Sure. And sometimes like I will in fluoro, it's really nice if you can see the parents before the swallow study, because you can try some of these things even before you get to the swallow study. But if you can't, I know you can't always do that.
No, but do you do these elevated, the strategies during the swallow study with these children?
Yes, we do. We'll change
Okay.
their positionings. And again, I'm talking more with the bottle. I know this is a little different, but like we will change their positionings and things during the study. We will note, like I'll always write the time. Like let's say at a minute, I tried smaller boluses, things like that. And you can note those things. And if for some reason but hey, sometimes the child doesn't participate and you can't get it during it. That happens too. This is real life, right? So then afterwards, I would bring that child back and I would try some of these things and train the parents. So to answer your question, I would try it during the study. I would, but sometimes it's just not, feasible, and that's okay. It depends on the situation, the child, and how stressed they are. So
Also the volume for the room. So I think the room is so highly I mean, there's so many patients here that, we'll have to do 1 week. So that also plays a role here. But yeah, so how long does it take for you to finish one VFSS for the child, if I may know approximately, with the intervention, with the feedback and other things?
like the whole time of the swallow study?
Yeah.
Okay, for our infants, we try to keep it under 2 minutes. We keep them short. So we will, let's say you're feeding them, we'll turn fluoro off at times, let them keep feeding because their coordination can look different as they continue to feed. Then we'll turn fluoro back on. With some of our older kids, we will go to like 3 minutes. However, that being said, like if I have a child, I'm over the 2 minute mark and they're aspirating everything and I haven't found anything that works yet, I'm gonna go a little longer, right? Because I want to see if something works. And we just radiated this child for 2 minutes and we didn't really find anything that works. So I will go a little longer if it means I'm gonna get more useful information. Yeah.
Can I just add something?
Sure.
So I think what Lauren was talking about earlier about doing a clinical or watching the child eat and just that interaction with the infant and the caregivers is really important and can also help reduce that fluoro time immensely because you're seeing what they're using. You're seeing if like from the get-go you see that they're having a hard time pacing. That's something you're going to plan to address during the swallow study. So it gives you a nice idea of what those modifications will be during the swallow study itself. So it helps you go into it with this better plan instead of kind of starting from the beginning and trying to figure out in the study what the issue is.
You guys are able to, sorry.
I had to ask something. What is the earliest age you will perform a VFSS at? We're talking
40
at a 34-weeker.
40 weeks. 40 weeks, and that's their adjusted age. So you have to wait till they are, 40 weeks adjusted. Yes.
So we have a program of Biomi at the NICU, that at the tertiary hospital I work at. So we've had a couple of, in fact, a lot of these kids, the way you've described, where the oral motor part was the main issue. So we never really take them up for VFSS because they're still very tiny. But by doing Biomi continuously for 10 to 15 sessions, we have found that once they're oromotor and once they're more regulated. So when you say that they're not realizing the bolus in the mouth, when you do the intervention for 5 minutes, it's just a 5-minute program. Sometimes the child just does not allow me to do the program. I'm just holding the child and just rocking, just giving them the regulation. And then moving on to the OMS for 5 minutes of Pyomi. And we initially, I would love them to suck on a paladip, but we start with a Vati spoon. So the spoon has 0.5 ml of liquid
Great.
that
That's great.
we put at the lower lip, and I allow the child to suck. Once the
Great.
child has an NNS of at least 8 sucks per burst without my
Okay.
stimulation. So when there is NNS during the stimulation, and which is voluntary, when the sleep wake cycle is also setting in, the circadian rhythm of a child, when the child is able to wake up voluntarily when I'm doing the pyomi, because consciousness is also a very important state in preterm children. So it's not so, honestly, I have not yet done a VFS on a child less than a month of just of proper age, because we would rather wait it out, and we get the bronchoscopy done so we know if there is any structural damage for sure. But we've generally seen the Vati spoon goes much better. It helps in controlling the volume of the liquid actually. So yeah.
Yeah.
You guys are able to see the barium swallow picture there now?
Yeah.
Dr. Thiru, may I ask a question?
Yeah.
Yeah, hi, I'm Dr. Kanimuri. I'm the radiologist who works with Dr. Thiru. So I have a question for Lauren. So it's quite interesting what you said, Lauren, about altering the volume of the bolus, because I think that's something I haven't considered before. So you can see on the screen the barium study that we did, and you can see on that there is aspiration. So this was done with the child supine, and we'd used a syringe to kind of give a constant bolus.
Right.
So like what you'd mentioned about some babies having kind of pulling it in the mouth with the bolus being too big. So I'm starting to wonder whether, like, how do you tailor the amount of bolus that you give for the child? Do you always like start off with a really thin stream and then keep increasing the volume of the bolus, or how do you normally tailor it?
Yeah, and you could do something like that. We typically, I'll tell you, we don't really use syringes a lot.
Yeah.
Okay.
We'll use like, I actually love how we were talking about the spoon too. Like I would use that, and that's exactly right. You could start with half a cc and kind of work your way up. And I think what you're doing too, again, you're accounting for that bolus size. And I think they're much more successful with that because you're using a strategy, right? You're
Right.
helping them. You're helping them with that oral phase and the control and everything. So I actually think you're doing a lot of really good things with that. But yes, if you can not use the syringe, I would start there too and use more of your spoon and cup and things like that.
So
I'm
really suggesting use whatever they are using at home
Yes.
during the
Yes,
study as well.
absolutely.
Okay.
Yes, absolutely. Absolutely. And again, have I used the syringe before when a child's like really not cooperating? Sure. But always in the back of my mind, I'm like, this isn't it really a really good representation though of
Right.
what they're doing, because it's not the vessel they're drinking from. And that within itself can affect the swallow physiology and the
Right.
oral and pharyngeal phases. So like I'm even looking at this right here. Look at how much contrast is spread throughout the oral cavity. This kid isn't even getting a good like bolus formation, posterior oral containment, all these things. And I'm looking at this kind of like, I would expect this child to maybe struggle with this a little bit.
Yeah.
It makes sense what you're seeing, I guess. Yeah,
Can I add a few things?
sure.
Yes.
Even before so I think the key thing is don't get fixated on the aspiration and don't rush through because one, this was a preemie kid, had NICU, had NG tube, so there were a lot of insults on this kid. So seeing a little bit of aspiration should not make you rush through things, and you need to start to think more about this is a normal process for a preemie kid, and I need to just optimize whatever skills they are not good at and just make that better rather than chasing. I wouldn't even have done a DL, looked in the OR. I would have first started with just trying to improve the skills, and then the swallow study again. You need to say what happened during the swallow study. So the initial barium swallow, if it showed aspiration, it's just one little thing. Clinically, the kid was not showing any signs of aspiration. The kid was showing more oral skill lacking, which needed to be worked on. So I would have started on that first to work on that. And if there was concern clinically that this kid is aspirating, that's when I would do the VFSS
Mhm.
again, probably a month, 2 months later, just to get an idea like what is happening. But I would start off with first clinical assessment and work on the swallow skills first. And a lot of times, what you all you have to do is reduce the amount of boluses which is given so that the kid can learn to coordinate and then move on that rather than. So the reason Pallade was working on this kid is because it was a controlled bolus which was being given, which was enough for this kid to work through. Once you give the bottle, the kid needs to learn to one suck and swallow, and that coordination needed a little bit of time. So the good things are the kid has gained quite a good amount of weight, which is good. So again, more reason for me not to worry and not to rush to put the NG tube in because that will again hinder some of the development which is happening. So some thought needs to be given on what the kid is going through, and based on that, the investigations needs to be proceeded.
I think use of the fees was really great as a study that you can complete in the interim between swallow studies, so you're not having to repeat those or feel like you need to repeat them. And then try some of the strategies you've been working on clinically while doing the fees so that you can see if it's working, if the pacing strategies are going well, if there are modifications you can make during the fees so that that informs your practice when you go and start working with them clinically in treatment as well.
Great. Yeah.
Yeah, thank you for the input. So the take home from this case is, the first, in the first place, there was an aspiration in barium swallow. So we all thought there is, something serious. So, immediately we started on NG feeding, and then we did all the, assessment, like, fees and everything. Once the fees, we thought it is safer, then we remove the NG tube and then send the patient to home on the regular skill training and other thing, and we'll be waiting for some time for the patient to come back, whether the child is going to improve, because the child is too young to brand it like the child is not able to swallow or anything. Maybe little later we can think about doing VFS or something in case if there is symptom persists. Otherwise we can just leave it, right? Is that right?
Yeah,
These
close
great
clinical
points. Yes.
monitoring. Just
Yeah.
just like when you see this kid back in 2 weeks, uh, I'm expecting this kid will be better than what he was,
Right.
and just continuing to monitor that process is important. Typically for us, Natalie and Lauren will monitor that and reach out to us if there is any concern.
Right. Thank you so much. So we'll move on to the next case. Alifia, you're ready for the.
Yes, I'll just share my screen.
Yeah, please. Yeah.
Is it visible?
Yes.
Yeah.
Uh, good, good evening, everyone. So I've been requested to present two cases. I'm a speech language pathologist, mainly working in the field of pediatric dysphagia since 2 years now, dedicatedly. I work with tertiary care hospitals in Mumbai, one of them being affiliated with UNICEF, where we work with children typically who come to us with malnutrition and present. Most of them are medically complex cases. So for this forum, I have chosen two cases wherein the decision-making process will be highlighted from a therapist point of view. Moving on, I would just like to read the disclaimer quickly. This presentation has been, just a second, has been presented for academic discussion and education purposes only. The details have been de-identified to protect patient confidentiality. The information presented should not be interpreted as medical advice or a substitute for professional clinical judgment. Management approaches may vary depending on the individual child's clinical condition, institution policies, and a treating team's discretion. Consent has been obtained from the parents for sharing the case details. We all know what feeding disorders are, and as ICD describes them, we generally give these codes for feeding difficulties, where our 63.3 plus added if it's a chronic acute disorder or if it's unspecified. I'll move on to my case one, where it was a male child who was referred to us at 1 year, 11 months, having the main complaints in difficulty in managing oral secretions. So he had constant drooling. Even while he was not being fed, he was constantly coughing. He was inability to gain appropriate weight with oral feeds. When he was first referred, he was below -3 SD for his age. He did not have the appropriate feeding milestones. So when we go further into the child's medical history, he was a full-term vacuum assisted delivered child. He did not cry at birth. His birth weight was 2.75, head circumference 35 centimeter, which was appropriately increasing as throughout in infancy. He was ventilated in the NICU. At 4 months, he had jerking behaviors, multiple events in the day. At 7 months, paroxysmal events started, after which a regression in milestones was noted predominantly. He had achieved head control till 7 months, which was lost. His MRI at 1 month and the recent MRI both have shown a severe encephalomalacia due to a hypoxic ischemic injury. The final diagnosis given for this child was global developmental delay with dystonia, with epilepsy, with laryngeal cleft type 1. I'm not going too much into the medical details. I would like to focus more on the feeding part. So when this child was brought first in February 2024, a laryngoscopy was done, giving the diagnosis of type 1 laryngeal cleft, and a laryngoplasty was done to see if feeding improved after that. During the period of Feb to July, the follow-up was lost, and hence no instrumental eval could be done to see how well the child was coping up. The parents came back in July 2024, after which contact was re-established. At that time, the child was put on a keto diet, had again got aspiration pneumonia within the 5 months period. So it was seen that 2 months to 3 months after the laryngoscopy, aspirations had reduced. There were no LRTIs, but it did increase after 3 months. So at the same time, because oral feeding was unsafe, he was also undertaken for a PEG. In April 2025, finally, an endoscopic laryngeal cleft closure was done. Just to explain here, between July to April, he was not fit to undergo a surgery. Once one surgery was done, his seizures started to increase, and because he was medically complex, we could not operate on him before April, and it was he was deemed unsafe for a surgical procedure. Hence, it took so long. However, because PEG was introduced at July, the malnutrition part was taken care of. I'll just play this before the laryngeal cleft surgery was undertaken. If you see the chest retractions, he also has arytenoid prolapse, and he has significant stridor, which has recently again increased. Stridor is better with positional change. It's better when during the night, as the parents say, because he's propped up. When he is in a 45-degree reclined position. However, when he's seated, it increases significantly, especially during activities. This is his recent laryngoscopy done just last week, where it shows grade 2 adenoids, both vocal cords are mobile. The laryngeal cleft has healed well. However, there is redundant arytenoid mucosa which is prolapsing, which can see me. So this FEAS and VFSs was done after the second laryngeal cleft, the laryngoscopy was done. We will just have a look. You can hear the child coughing and gagging. This was the third attempt at FEAS. One reason why FEAS could not be done earlier was also that the child had extreme oral aversion, perioral and oral aversion. Wherever anything introduced even near the lips, the child used to gag and vomit. This FEAS work was done around January 25, wherein he had undergone 1 year of sensory integration therapy. He was now tolerating some textures and hand touch around the mouth, especially around the lower lip. So hence we tried this. The reason a VFSS was also tried earlier, but it was not successful, as he used to have focal seizures when we tried to hold him a little and introduce, and like we discussed earlier, it was not giving us a functional result of how feeding and swallowing was happening. We tried with the spoon first, wherein this is just a part of the study where there was a lot of drooling initially, and everything that was introduced via the spoon led to a head jerk, as you can see, and the entire bolus was just held up in the mouth. Dystonic movements, especially of the jaw and head jerks, are still present when the spoon is introduced. Hence, to see if laryngoplasty had worked, we tried, sorry, we tried the bolus with the syringe, where we saw that there was a little delay in the initiation. There was some residue present at the valleculae. However, he was swallowing well, and there was no frank aspiration on oral feeds. Let's come to the clinical evaluations. So it was evaluated in 3 domains, where initially from 1 year, 1.1, 1.11 to around 2.5, he would barely respond to his name. He would just vocalize. The OSM evaluation revealed that he had a severe peri and intraoral aversion, even to touch via the mother. The lip seal was absent. The tongue did have anterior posterior movement. Right response was there. However, it was severely dystonic. The jaw was dystonic. Any touch around the perioral, the child would just jerk and go into a tonic reflex. Swallowing reflex was difficult to elicit. There was no HLE upon examination. The moment the finger was introduced in the mouth, the child used to vomit. However, initially, in the extreme initial, at 2 years, reflex was poor. He was just aspirating on his saliva. We had to orally suctioning him. As he progressed with therapy, we'll see that later. The voice was intermittently loud and always gurgly. Other signs of distress were arching, refusal to feed, crying, head turn, that was also dystonic. He had no cervical control, increase in limb tone, fatigue, and focal seizures. So we'll just quickly go through. We've seen what VFS showed us. The goals that were worked upon this child primarily was sensory regulation by an autist, where there was a transdisciplinary approach that was taken. The autist worked with the child first for posture and for sensory regulation. She also guided us as to how we could proceed on to desensitizing him around the mouth, primarily for evaluating how safe it was for oral feeding, and then to reinstate oral feeding once the cleft surgery was done. To reduce posterior drooling, that really went down with the help of the physiotherapist also, when she gave us positioning and as the tone improved. To improve swallow initiation, strengthen and facilitate oral motor movements to improve the range and strength of oral musculature, and the guidance on a whole child approach. I'll just come to this in a minute. So when I say transdisciplinary approach, it was a combined effort of physiotherapy, occupational therapy, and myself, along with the ENT, the neurologist, the pediatrician. All of us were in constant touch throughout. So as we know, the physiotherapist did her work of positioning, of increasing the limb movements. Sensory integration therapy also has worked wonderfully with this child, where initially she just started with dry non-food item play with him. We went on to more wet play. He currently also now allows to have food around him, is feeding with the spoon, as we'll see in the next video. He now allows some touch. He allows his mother to take his hand towards the food, mash the food, move it around his hands, around his mouth too. A very important part of this entire case I want to highlight here is parent training. As we were focusing on feeding and swallowing because the child came to us as a malnourished child, focus on communication and language had also taken a little back seat. So while we train the parent to do sensory integration at home, we also train the parent in the naturalistic milieu approach to take opportunities at home to talk to the child, communicate, because he used to have hospitalizations in and out. So around mealtime, around bathing time, sleeping time, to improve his engagement with all, which also helped us eventually in feeding the child. And for OSM, we started with basic passive exercises for the tongue. Just giving deep pressure around the jaw really helps in reducing the dystonia. Once that's more stabilized, we started introducing a flatter spoon around his lips. We finally went on to moving that spoon on the gums, on the tongue. That took us a good 8 to 9 months. And now we are finally on feeding him. He is managing ITSE level 3 consistencies now. So I'll just show a quick video of when I mean, what do I mean by wet and a wet non-food item play. And the mother added an element of texture here, where in water she's added leaves, as well as she's added sponge, where the child, as you see, the child is holding his neck intermittently now, is engaging via his senses more. So introduction during therapy, the Z vibe is off here. So because he is on keto diet, he has a very specific, like you see here, he is showing no aversion to small foods being introduced in the mouth. This was done after 8 to 9 months of just desensitizing him to the Z vibe too. And this is the most recent one at him being given via the spoon, where the spoon is just placed at his lower lips. He takes it in, and then he has these jaw munching movements. So when he's fed around 20 spoons. That's for around 10 minutes, 2 times a day. Now major nutrition is definitely via the peg. Also here to note is that the mental health of the parents, because they were in and out of the hospitals, a lot of support was provided from all the therapists. And that's what we meant by the whole child approach. We help them maneuver through different phases of the of the medical part, as well as the therapeutic part. Plus in Mumbai, we have, sometimes they travel, they stay very far. So follow-up is lost, but they keep a follow-up online, where online we monitor the therapy program that's given to him. And that's how in the last, I would say around 2 years, we have come to a point where he's swallowing better. He's not having any aspirations as of now. We are feeding him consistently twice a day, and hoping to move further. Should we move on to the next case, or should we engage in discussing this first?
I just want to say this was excellent. I think how you evaluated, managed, and treated this patient was, I don't think I have any other suggestions.
Yeah.
I think the key takeaway points, multidisciplinary approach, especially with physical therapy and improving their breath support, head trunk control, those types of things are only going to help with swallowing as well. So I think this was excellent, I have to say.
Thank you.
Yeah.
If I could just add,
Well,
it's really, really important, like you emphasize, the parent training component and just walking them through realistically what it's going to look like with this child at home. And a lot of times I know that parents get discouraged with the timeline and
Yeah.
how slow feeding progresses,
Yeah.
but like Lauren said, your multidisciplinary approach was fantastic in making sure that the whole child and his skills are being addressed. So fantastic work.
There's one thing I would like to also add is that we, before the peg was done, so there's always a lot of anxiety around putting the child on peg and whether he will ever come back to oral feeding. We connected them with a couple of parents who had a child with a peg, so it helped them reaffirm. And also, when all the medical professionals are on the same page, where everyone says the exact same thing, and also having a team. So I have a wonderful team of ENTs and pediatricians whom we work with. So that really helps.
That was really good. A great
Yes.
idea in connecting them with those other families, because
Yeah.
oftentimes they're so focused on this is my child and it's only happening to
Yeah.
them when they can see comfort in others. So that was excellent.
Yeah.
And this is
Yeah.
I'll just,
Nikhila. Oh, good. Is that Dr. Mehta?
oh,
Sorry.
Nikila, go ahead.
Oh,
Nikila,
I
go
was just
ahead.
going, yeah, I was just going to say I love the use of the feeding tube. Also, what I always tell families is that it takes the pressure off of them and off the kid to take everything by mouth, and it takes kind of the anxiety around it out because you know they're getting nutrition. So I love that you did that. And then the other thing is, I think sometimes we think that the win is getting everything by mouth, whereas
No,
obviously,
that's not.
especially are. I mean, anything by mouth is a win because it's
Yeah.
pleasurable. Obviously, taking stuff by mouth also leads to improvement in other cognitive abilities and whatnot. So, I mean, that's an impressive case. Just the longitudinal course that was great. Thank you so much for sharing this case.
Thank you. And also, one more thing, we encourage the mother to eat with the child around her, to just introduce him to a normal family meal time, to let him just extend his hand and take anything from her plate, to make it more like a normal family where otherwise it's not there. So I think even that, supporting them through the process, I felt was equally important. And like Dr. Nikhila said, that any oral feed is a win-win and without a lot of struggle.
Right.
So yeah, also there is
Yeah,
one.
and doing the cleft repair, even though
Yeah.
it doesn't get him to full PO, it takes away, makes him safer, and so
Yes.
it can do something. So I think that's a great point. That as surgeons, sometimes I think we want to fix it to like 100, 0 to 100, but even if we get 0 to 20, 0 to 50, that's still a win, especially for kiddos like this. So that's great. Thank you so much for sharing.
There is a question in the chat box, NG versus PEG. When should long-term G-tube be considered? So for me, I would give traditional therapy for 3 months, extended to 6 months. India being India, unfortunately, we have a couple of kids who extend the NG tube insertion by 9 months and 11 months. And even after intensive therapy twice a week, thrice a week, there is no scope of improvement beyond a point because of the comorbidities. That's when it becomes very important for us to counsel the parents that it's stressing out the child. You can't have 1 hour meal times every 2 hours. When do you have time for anything else around the child? Also, it's not gaining enough weight. So, weight monitoring is my second part. Even though the child is not having aspirations but is progressing extremely slowly in his oral milestones along with other milestones, is when I would consider a peg. We've also had cases where we have reversed the peg. We've put in a peg for weight management and we have trained the parent through a year or two and we have reversed the peg. So we've also had cases like that.
So the answer to that question is, how long can you have the NG tube? When should you consider PEG? Basically, you need to say what will be the progress of this kid. So, for example, this kid with HIE, we know that it's a long-term thing. It's not going to be fixed soon. So, for those kids, it's better to think about PEG sooner rather than later and get the NG tube out. If you have a condition where you think in the next few months things will get better, say has a vocal cord palsy or some condition which will get better, in those cases, using NG tube for 3 months, 4 months, 6 months is fine. But you need to have like an end goal to say this kid is going to improve. I'm seeing improvement. Though those are okay to push for the NG tube, but I think as soon as you think that this kid is going to need long term, we should be pushing for PEG. Um, it's a good case. I think what I want us to do is to break this down at different stages, what is being done and what to expect. Because when the child came initially, we knew that this kid has a lot of other medical problems, and a lot of these are associated with it because the kid brain is not normal, has not been able to control the secretions well. This is typical of a kid with HIE, and you need to take one thing at a time, which was rightly done here, but I'm just highlighting those steps which needs to be taken. One, to establish this kid is having a safe swallow is important. The second thing is continuing to have approach of therapy, which is important in this kid is PTO2 is also equally important because as the kid's muscle tone gets better, some of the swallowing will get better. So it is important that the PTOT went along with the swallow workup and swallow therapy. And then the question about the laryngeal cleft, and I think like Nikila pointed out, when that was recognized, it's important to fix that. And then seeing a slow progression, like it was rightly done here, to just work through the process of getting the kid slowly better and keep the parents' expectations because they need to understand. The other thing is about the secretion management. If the kid is not having too much of drooling, it's okay. But if, say, the kid had a lot of drooling, then sometimes you might have to control some of those secretions so that the kid is able to swallow a little better. Anything else? Thiru, you would add anything else? Nikila?
Deepak, yeah, I want a clarification. I mean, I'm not going to add anything. So, fantastic presentation. She's done everything well. So, in a little different situation, like if the child is having HIE and all these neurological issues, and also instead of laryngotracheal cleft, if the child is only having severe laryngomalacia, there is no cleft, but laryngomalacia is very severe. Will you fix that as well? And before going into all this therapy, or you will just treat thinking that the laryngomalacia part will improve on its own?
So, sir, I've
Um,
had a case of dystonia with laryngomalacia with severe HI. So, in that case, we did wait for a year and a half, where we kept working again on this child was also fitted with a PEG. So we waited for some time with the ENT's opinion to see if it resolves and keep working on oral exploration, perioral, intraoral awareness, exploration, all of that, because we were not worried on the nutrition. However, when it did not subside after 2.5, the ENT himself decided to undergo a supraglottoplasty. So I would leave that decision to the ENT, because if oral feeding is not a possibility right now, if safe oral feeding is not an option for me right now, I would still focus on facilitating more normal movements around in the child as well as keep providing more exploration. So when the time comes for oral feeding, and if the child is still so aversive that he's just spitting out the food, I'm still not achieving my goal. So I take that time to build up the child's sensory regulation around food and wait for it to subside. Or as the ENT says, in our team, they have taken up children for supraglottoplasty even very early in life. So that decision is more with the ENT than me.
That's an
Yeah, so
interesting conversation. I think that we are a little more aggressive or a little more, maybe aggressive isn't the right word, but from a laryngomalacia perspective, the procedure tends to be, especially in severe cases, it's a pretty straightforward procedure, and the kids usually do pretty well. Dr. Thiru, I would say for us, we would probably do a supraglottoplasty earlier because you take away that suck, swallow, breathe issue, or for instance, if the epiglottis is not inverting properly or the arytenoids are dragging food in. I think, in my opinion, if the dysphagia is leading to aversion, I tend to think of it as, well, if we can improve the dysphagia with a fairly straightforward surgical procedure that has high success rates, then I think that that is reasonable to do first. That's kind of the way I take my stance on it. Dr. Deepa, I don't know if you have other
Yeah.
thoughts.
So the only thing is, whenever you're doing a supraglottoplasty on these kids, you need to set the parents' expectation right. And you need
Absolutely.
to say, what are you trying to do? That needs to be very clear. Say, this kid does not have HIE, a normal kid with laryngomalacia. The outcomes are very different to the kids who have all these things going on. So I think the key thing would be to keep the expectations right, to say, hey, we are trying to just optimize everything for this kid. It might not be perfect because the kids might still have some stridor, and you're not going to fix all the stridor. You're just trying to make things better for the kid so that the swallow gets better.
Yeah, I mean, I think right, waiting a little bit is totally reasonable, and we always engage in therapy and all of the non-surgical things as well simultaneously. But I think, I don't know, Deepak, if you feel otherwise, but we probably wouldn't wait till 2 years. Maybe after some months, even if it's like 6 months, 8 months, where you'd expect, even up to a year, you'd expect the laryngomalacia to improve, and we're really not seeing significant improvement and continued feeding issues, then we
Yeah,
would probably operate.
I agree with that. I think in those situations, it's better to just fix it, or fix it in the sense, make it better for the kid sooner rather than later. Rather than struggling with therapy more and more, it's better to just say, if I can make it a little better for this kid, it's actually will make proceeding with therapy a lot more, lot better.
Thank you. Alifa, are you going to present the next case? Uh, You need to unmute, Alifa. You
Sorry.
need to unmute.
So
Yeah.
I wanted a common consensus on whether would we like to see more structural deformity cases now, or would we rather see a neuroregression case? So
Anything which
anything is
gives
fine.
us a different something different to what we have
Okay, sir.
already discussed.
Okay, sir. So, sir, I would rather present a case which I have had mixed feelings about. So I'll just go on to share my screen. Just a second, please. So this case was a 1-month-old child who had no significant birth history. He was admitted in the NICU post respiratory distress and then was diagnosed as aspiration pneumonia. The mother kept saying that when the child was discharged from the hospital, she was breastfeeding the child, and the child was breastfeeding well initially in the initial days. post 15 days to a month. In that 15 days, he used to feed, cry intermittently, leave the nipple, come back again, and had constant coughing while he was breastfeeding. Hence, she had shifted him to a bottle, and things were the same with the bottle, and eventually he landed up having aspiration and pneumonia. Also, one significant thing that she pointed out was that he had nasal regurgitation of liquid while he was drinking from the bottle. So, whenever he used to drink and then cry, milk used to come out from his nose. He had often a gurgly cry. Oral feeds were inefficient. He had not put on any weight from 15 days to 1 month. So during the bedside clinical eval, unfortunately, I do not have videos of this child as a parent did not consent me to put it. Routing was present, tongue transverse was present, rise response was present. On OSM evaluation, slight mild aversion was there but was manageable. His lip seal was present as at rest. Tongue strength. So when the gloved finger was put into his mouth, initially the NNS was good. It went to as high as 11 sucks per breath, which he was managing fine for the first 2-3 repetitions. And then the tongue used to fall down, and he used to leave the finger and start crying again. The jaw was stable. There were no extreme jaw excursions here. Oral pooling was absent after he was fed. The swallowing reflex was slightly delayed but that was not very significant here. The HLE, however, every time he used to swallow, there used to be a slight sound, and obvious strength was seen by him to even hold the bottle well into his mouth. The mother had never tried it via spoon or a paladin. His voice was intermittently gurgly post swallow. It used to be gurgly even in his cry post swallow, which used to eventually settle. The other signs of distress was he used to cry incessantly. Fatigue was present after every 7 to 10 sucks. There was nasal regurgitation and back arching. He was taken up for a VFS evaluation, where in the first evaluation, as you see, it's not very clear. However, you can see a little of nasal backflow here. During the second one, he was fed via the bottle, and the bottle was removed, and this was then recorded, where you see and was slowed down. He was struggling in the pharyngeal phase. Once the bolus was into his mouth, there was obvious pharyngeal incoordination seen, and there were microaspirations also noted. So there was velopharyngeal incompetence leading to nasal backflow. There was pharyngeal incoordination, and microaspirations were also seen. So the entire treatment plan, one was he was put on an NG tube as he was admitted in the NIC on the first day. It took a lot of our counseling to have the mother let the NG tube be there for some time until we figured out what was really wrong. We also wanted to see that if we are strengthening the tongue via Pyomi Plus, and he was tolerating Pyomi Plus by the fourth session. So we wanted to see that if we do that for at least 4 to 6 weeks and we let development also take place, is it becoming better? So we did start with Pyomi Plus here, and we also tried positional changes. So he was when the mother used to feed him via the bottle, he was quite flat and not held close to the chest. She used to feed him holding him like this. She was asked to make more skin to skin contact for the child to calm down. One, secondly, she was shown how to elevate the child and also keep him into a slight sideline position to see if nasal backflow reduced, which it did at least by 50% initially. And one novel thing which we tried here was velopharyngeal inconsistency was noted by all the physicians treating the child. With the pediatrician and with the prosthetist, we made a temporary palatal lift prosthesis, seeing that if we hold the palate, if the soft palate into place a little up when the bottle is being fed, does it help in the nasal backflow? We were a little worried here because we were worried that the nasal backflow, the remaining milk may just flow into the pharynx, into the larynx, and the child may aspirate. But the palatal lift prosthesis didn't really work out with the child. We tried it a couple of times. We had customized it, but didn't allow us to place it. This child, unfortunately, was lost to follow up. It was an outstation patient. So they've been coming in and out, in and out. So when they visited us last, they were continuing to do PYOMI as we had asked them to do. The child is now 8 months of age and has been progressing well on his motor, speech, cognitive milestones. When he was evaluated on feeding, he still showed slight fatigue. However, there was absolutely no nasal backflow. On a repeat VFSS done elsewhere, which was reported to us, pharyngeal incompetency was still noted with slight residue at the valleculae. However, there were no microaspirations now. So, I guess development did take place here, wherein the pharynx and the soft palate was involved. My line of thought went into vagal nerve involvement. The MRI of this child was also clear. Genetic testing was also clear. So I'm very open to suggestions here that was there anything else that we could have done, except because we could not even, we tried thickening the milk a little to see if it was GERD and if it was, if the nasal backflow stopped, but the child was not able to manage even slight thickening of the milk at around 4.5 months of age. That's when we'd seen him last physically. And then they've just followed up on call. So currently he is feeding, he is gaining weight, although he's still under moderate acute malnutrition. He's under -2, -3 SD. His milestones are good. I did hear him babbling on the screen last time. He's feeding well, but yeah, the question remains, why is the pharyngeal inconsistency there? Anyone, any thoughts on that?
Yeah, I'm going to throw out, this is Nikila, I'm going to throw out something that is a little controversial, but we actually published a case report very similar to this child's a few years ago. Did anybody check his tongue for a tongue tie or any kind of movement restriction? Because
yes, we did. Yes, it wasn't there.
Nothing
no, it
at all.
Wasn't. No, nothing at all.
Okay. Yeah, I mean, that's the only other thing I would say. If he's a neurologically normal child, sometimes even if we don't see an obvious band of tissue, but functionally he's acting like that. Basically, our triad that we found that we kind of look for is nasopharyngeal regurgitation, reduced base of tongue retraction. These are all on the video fluoroscopic swallow study. Reduced base of tongue retraction and pharyngeal residue. And what we think, and I think this is an area of interest of research for us, for me personally, is looking at the impact of impaired posterior movement of the tongue on pharyngeal squeeze and pressure generation. Because I think that whether it's neuro, obviously those kids can have oral motor weakness, including their tongue, and that would make sense. But sometimes in these otherwise neurologically normal kids, it's the exact same situation. Normal MRI, they make progress because they get stronger. But like our child was not till 2 years, we just decided to try. He didn't have an obvious, thin band, but had maybe a palpable little bit of tethering, and we released it, and it improved significantly the feeding. So that's the only thing I would think about just looking at. And if the child, is the child still has an NG in place, or everything is PO now, is by mouth?
No, so he is orally feeding. There is
Okay.
a little issue in weight gain. And
Yeah.
neurologically normal, when I mentioned neurologically normal was on basis of the MRI per se. He
Okay.
did, there was also a question of genetic involvement, but even that was cleared
Okay.
up.
Yeah, there is,
So,
Yeah, I mean,
Nicola, sorry. There is in the chat box, Dr. Srinivas is her gastroenterologist. He says that, it's too early to say the child is neurologically normal.
okay.
So,
okay.
for Dr. Dr. Srinivas, you have some thoughts you want to put it in?
Uh, Thanks. Sorry, beautiful presentation.
Thank
Just
you.
enjoying the presentation. No, I just meant that a number of times we deal with a number of other conditions. Like, for example, we have neonatal jaundice, neonatal cholestasis. They all appear neurologically normal. When we follow them up at about a year, then we sometimes see that there are certain places where they are not neurologically normal. They might be autism, they might have a little bit of speech delay, they might have a little bit of fine motor skill issues, and sometimes just that 1 to 2 month delay. And on follow up, you kind of realize that, okay, maybe there was an element of perinatal hypoxia, but MRI can be normal. So I presume it's too early to say neurologically normal at that age. About a year is a good time to assess to see if they're all doing well or not. But I completely agree. It's difficult. Uh, if you find somebody, you just at that point of time, maybe the best thing to do is to put down what are the problems that you have. So if you made a diagnosis of velopharyngeal incoordination or pharyngeal incoordination, just put that down as a diagnosis and keep following them up to see what they evolve into over a period of time.
Okay, sir. Thank
And
you.
I love the fact that everybody discussed about PEG as more as something like an assisted feeding.
Yes.
So a lot of our Indian parents get disappointed the moment they say that they can't feed orally. But PEG is to empower them to get the nutrition right. And I really love the fact that Tequila pointed out that any oral is a win, and the goal should be adequate nutrition. And the goal is not only oral feeding. Feed orally, and we'll assist you with a PEG. So beautiful points brought out in the discussion. Thank you.
Thank you.
So, just to add to what Sir said, this was another point we wanted to discuss. So, in some parents, when we counsel, when we realize that the child has chronic feeding disorder, but the parents are, educationally or socioeconomically not.
I think we lost her. Okay, no issues.
Yeah, I think what Dr. Srinivas said is a good point. Sometimes these kids take time to evolve. So it is key to keep in mind, especially if we think otherwise everything is normal, still the swallowing is not normal, then you need to start to think like maybe it is a slowly evolving thing. So that's a key point, is to just keep that in the back of mind and not lose it to say, okay, everything is normal and going on. It needs to be reevaluated at certain points to just make sure the kid is not falling back.
So one difficulty we consistently face is that when patients are out of town, they we lose follow-up because of that. Second is because of the socioeconomic conditions. They cannot travel back to us, but we try having a telephonic conversation with them from time to time, at least every 6 weeks. Just drop in a message that is the child doing okay. If you can't come back to us, please visit a pediatrician in your area. Just make them aware of the difficulties the child has been facing. See if you find a local therapist there. A lot of times we connect them with colleagues in different cities and then have them going around the entire procedure without, having a gap in between, just for the continuity to happen. But this was one of the cases which because was orally feeding okay and the aspiration settled, the follow-up was lost, unfortunately.
Yeah.
Shall we go on to the next case?
I think we do same strategies as well. It's not just your part of the world. Sometimes we do have problems with parents not coming from far. And what you're doing is absolutely fine. And that's to, I'm just telling everyone, it happens to us as well, that sometimes the parents are coming from too far off, they can't travel. So doing what we call as telemedicine here is absolutely fine. That's a good way to just keep in touch and make sure the progress is going fine. So that's a good strategy.
Yeah, and I would say if there's a local SLP or OT or physician who's managing it, as long as there is a concordance in the plan, we try to do that when we have, families coming from far away. I don't know if that's, doable in the settings with especially with lower education, lower socioeconomic status. I'm not sure, depending on where they're coming from, but obviously you all are very good at taking care of these kids, and I think some of our problem, we have the same issue where we go out in the community and people just aren't as familiar with difficult cases or thinking outside the box on some of these patients. So like educating the community, other providers in the community is one way to make sure, hopefully the kid will continue to progress even if they're not under your watch constantly.
Yeah. So, Lauren, Natalie, what do you do for these kids who are from far off? Because you do a good job with communicating with the SLPs. So, can you tell what your approach is typically with these patients coming from far off?
Sure. A lot of times, I actually see a lot of kids that come in for a week of getting care and they're international and they'll come and see all the specialists and they say that, or 4 or 5 hours away from where we are here in Houston, and they'll say that they're in rural communities or places of the world where they don't have that access to the speech therapist and team we have. So oftentimes we come up, we print out a treatment plan, we talk about in person when they're with us, and then sometimes we set up like telehealth visits or calls, and we can really just help make sure that they are doing their home exercise program. And we make sure before, that initial meeting, we have a game plan for, hey, in 2 weeks, we'll call you to follow up, or in a month, or whatever it is, to make sure that they have an understanding of what that next step is. And also, utilizing the support they do have. Oftentimes, talking about the lower socioeconomic factors to consider, moms are going to work, so the kids are with grandparents or families, and so talking about how each of the caregivers can contribute and how the child can still make progress. It's just going to look different, and the timing may look different, and just help supporting them along the way.
I think that was
Can you
perfect,
guys
Natalie.
hear me?
Yeah.
Yeah, I got disconnected.
One other thing too, sometimes with patients who, just one thing to add, who are, they live far away, is I'll try to coordinate visits if they're already coming in for something else. So if they already have another doctor's appointment or something, I'll say, hey, can I catch you that day that you're already coming in for? Yeah, we try to get, as many visits as we can, kind of like Natalie was saying. But I will try to do that too.
Bhargavi,
And
you're back on.
same for any. Sorry, I was gonna say same for any procedures. Like if hopefully this child isn't headed that way. But let's say they get a PEG, maybe they do triple endoscopy, and something to look for any anatomic issues. Just trying to minimize or maximize what you get out of each time they come to you.
Yeah. So I totally agree. So I think again, we are all trying to do what telemedicine is something we and Thiru sir is also completely in agreement with it. Just to, I think while I was talking, it got disconnected. So these pediatric feeding, sorry, my daughter's around. So these chronic pediatric feeding disorder, children whom we are suspecting this, when we are not able to convince the parents, one of these strategies we had to start using is again, these children were otherwise taking oral feeds. But 1 minute. Yeah.
Bhargavi, maybe we'll move on to the next case. Then finally you can give your input. Sahana, are you ready?
Yes, sir.
Yeah.
Okay. I'll share my screen. 1 minute. So, I'm going to have a small presentation case study. So I'll be talking on feeding management, whom I'm seeing this child right now with global developmental delay and chronic aspiration. Ah, this child is 3 years old with a background of chronic bilirubin encephalopathy and recurrent respiratory infections and multiple episodes of sepsis with ARDS. Due to poor intake and repeated aspirations, the child has been on gastrostomy with fundoplication for the past 8 months. Before PEG, the child had poor growth and frequent hospitalization and significant stress for the feeding stress for the family. Neuromotor wise, the child demonstrates low tone, limited cross motor skills with only neck control, and and sitting with support is only achieved. And oromotor skills involvement are also limited. They've been in therapy with us just for about 5 months. I've not seen the child prior to this. So this child presented with poor swallow coordination with recurrent aspirations and multiple hospitalization. Nutritionally, there was failure to thrive prior to PEG. In addition, we saw significant oral aversion, irritability during meals, and high levels of family stress. So the challenges were not only medical, but also behavioral and a little bit of psychosocial as well here. So given these challenges, our goals were not only to maintain but also to develop the oromotor skills despite the long-term tube dependency. The emphasis was on skill acquisition, improving tone, control, and swallow coordination. We also aimed to reduce the oral aversion and to promote positive mealtime experiences and gradually integrate safe oral feeding. And at the same time, parent empowerment and realistic expectation setting were integral to our approach. So PEG was maintained as the primary source of nutrition. So because of this reduced the aspiration risk, the fatigue, and it supported growth. Oral sensory motor stimulation provided just not for oral integrity, but we also for functional skill building focus for tone stability and mobility and coordination. So slowly we have just started PO trials which are safe in Q-based exposure and with small volumes which are actually guided by this VFSS findings. So the plan was progressive from desensitizing oral aversion to readiness cues to therapeutic tastings and then monitored oral trials. This plan was supported by physiotherapy, occupational therapy, and medical monitoring. So currently, with PEG as the primary nutrition, we have now stabilized the growth and weight. So once feeding stress was reduced, we saw developmental gains. So there was better participation in physical therapy. So oral tolerance also slowly improved with limited taste trials. I've just started and the child has accepted without any distress. And since we started therapy, there have been no hospitalization. So hospitalizations have reduced and family meantime stress have significantly decreased. So our emphasis are at KKCTH is like an holistic approach. So the parent training was central. So with the parent always in the session and the parent having my number always messages me every week. So we worked on positioning, pacing, and recognizing stress cues which were taught to the parent, and home-based oral play like chewy tubes, resistive sucking, and sensory play. So because of this ensured consistency outside therapy sessions also, like now currently the child who was not taking anything orally have now started to have a milk in his feeding bottle consistently without any aspiration, which was checked with VFSS findings. So yeah, this was physical therapy is ongoing for postural support, and an OT is also there in communication for sensory integration. So this is what I am been I've been doing. So is there any comments and guidance on how to proceed further? And your advice is also appreciated. And later I have few questions also.
Well, I think your treatment plan is really good. And I think there's some themes I'm seeing even between yours and the other presentation that was with the other child more neurologically involved with those neurologic comorbidities and things. Really, it's the holistic approach, right?
Yeah.
It's the parent training and then the compensatory strategies. I think with these kids are huge. You know, the pacing, the different drinking vessels, the looking for their stress cues. It's all about how do we use strategies. I find for this population specifically that compensatory strategies
Yeah.
are really what you're going to be using with these children who have more of those neurological comorbidities, and that parent education too part as well. And I think too, because I feel like we've been talking a lot about the G tube, PEG tubes, and things like that. I think with these kids too, I always phrase it as having that PEG tube is going to actually help your child eat by mouth. It's going to support them eating by mouth. They'll have the nutrition, like you were saying, and the energy to eat by mouth, participate in therapy, and actually have pleasurable oral feeding experiences. And I think what that does is start to actually make changes in the brain and, use neuroplasticity to have these positive feeding experiences and improve their skills. So in the end, the PEG tube helps them eat by mouth. So I think those are kind of the common things I'm seeing with these cases and just with our discussions we've had today. Yeah.
So I have a question, not related to this, but this is a common pattern that I've been seeing here in our hospital. What's your opinion on advice as using a non-oral feed method, especially an NG tube, as a therapeutic role? Because temporary NG feeding, I feel, temporary NG feeding not only as like to serve as a nutritional measure, but also as a therapeutic approach to reduce fatigue and promote developmental engagement. So I want your opinion on this. Having NG as a therapeutic approach where I'm seeing just for 2 weeks maximum or for 14 days or something like that. And then for as to reduce feeding related fatigue and promoting the developmental engagement in physical therapy, child is performing well, slowly the child is becoming better. So what's your opinion on it? Because I always think that even if I am not seeing anything in VFSs, because VFSs is very short term, like for say 2 to 3 minutes only, child is allowed for an exposure. There could be a risk of aspiration even after 2 to 3 minutes. So even if that is safe swallow, I feel like sometimes the child might aspirate. So I feel having a non-oral feed as a therapeutic measure, we'll see how the child is becoming better. Then I know for sure, then something is happening. So your opinion on this?
If I could
So
say,
Hannah,
Is
or you go ahead.
no. Happy to hear. I'll contribute after I listen.
Okay, I was just gonna ask therapeutically, I think the first thing I'd think about is like nutrition and how the patient is doing nutritionally. If I feel like, while the swallow study didn't look terrible or there was no evidence of aspiration or consistent penetration that would be worrisome, I think there's a lot to consider before I would think to trial like a therapeutic NG tube route. I don't think I've personally ever done it, but I can see how it could be beneficial if nutritionally you need the child to be, increasing their weight
Yeah.
and you're not getting there. And also the buy-in from the parents, buy-in from the whole medical team.
Yeah.
Yeah, so basically, what we mean is there are these chunk of children who show that feeding itself is a very energetically, stressful activity for them, particularly these infant stage of GDD and the undiagnosed neurological children. So the behavioral features that we commonly see is these children come with, let's say, 4 months, 6 months, or even 1 year, 2 year, but they are developmentally not developing at all. And people, the whole concentration is on the seizures and what needs to be done neurologically, what is the genetic. But the child's basically most of the child's energy goes in just feeding through mouth. Nothing is left for the other development. So what we do is convincing the parent for peg empowerment, for them to realize that the child has a chronic feeding and all of that. We introduce NG feeds and we let them know that maybe for 2 weeks we will put the NG and see if we see any behavioral transformation, like the child's having a good weight gain, the child smiling. So all these social development starts happening in these 2 weeks. Then this technically empowers these parents to realize that, okay, maybe my child's feeding is different and I need to choose a different module. So this is what we mean. So I've been having this thought for a while that do you use NG as a tool? So that's where I say that can we use NG as a tool here instead of saying that NG as just a feeding module. Using it as a tool to empower parents, using it as a tool to make the child develop, and
So I think,
That makes
Bhargavi,
sense.
so I think we're just making different semantics to the same
Yeah.
approach.
Yeah.
So the first step is evaluation to see if the baby is able to feed orally, one, safely, and two, to get an adequate quantity that will make the child grow appropriately. So sometimes it may be safe, but the baby may be feeding too slowly, so you're not able to take enough quantity. So if you're not able to take enough quantity, you first point that out to the parent, saying that your child is taking too longer to feed than a normal child, for a reference. Make them understand that there is a problem. That itself takes some time because most of the parents are not willing to understand that there is a problem. Once that is told by, let us say, a swallow therapist in the form of a report, that is very, very empowering to the treating pediatrician or a pediatric gastroenterologist or an ENT person to say, like, it's like a progress card. Now look at this. Somebody sat with you for about an hour. They watched your child feed. They gave you a liquid. They gave you a semi-solid. They gave you a solid. And then they actually documented what your child does when he swallows. And they also compared it to a normal kid and say, like, this is the mark of your child. So now, if you try to feed, I expect your child to be at least drinking so much per day. If your child is doing only 50 to 60% of that, you understand that you're starving your child. Then the mother is willing to agree that she tried her best, but she is not able to do something. Then you put the concept to her like, we need to help your child. Let's assist feeding. And then the concept of trying to give what you're saying an NG feeding. For them to say like, okay, it's a tool, it's a help that will empower them to feed adequately, and then they can continue to feed orally. Then they realize that, okay, this is actually helping them. It's not exactly a step down, but it's a step up where somebody is also helping me and I'm also able to do something. And eventually you reassure them saying like, this assisted feeding can be removed at some point of time. like someone mentioned, a reversal of the peg or something, that at some point of time it's going to happen. Once they know that at about 4 weeks to 6 weeks of an NG trial, you do not aspirate on an NG, which means that there is no reflux. Then as a gastroenterologist, I'm very confident to say we'll just do a peg. Whereas a kid, if it has a lot of reflux or an episode of aspiration on an NG, then our approach is going to be very different. I'm going to advise a fundoplication along with a peg. So to know the difference between whether the child is a high risk for aspiration due to reflux and whether the child will benefit from actually the gastrostomy is why we actually trial from a gastroenterological point of view, a 4 to 6 week trial of NG feeding. In the process, I presume that baby is going to gain weight, become neurologically better, and it also helps you. That's the gastroenterology perspective.
So it's a win-win, yeah.
So
I
also,
think this is a great, so I was just going to say, great, this is a great discussion. I think with regards to specifically fatigue, I love the idea of, you're right, it is semantics, but even thinking about it as something therapeutic is really interesting. I think a good example where we probably already do this is, in like our cardiac kids who are gaining, who are becoming, increasing their endurance after surgery. That's basically what we're doing, right? Is assisting them with the NG so they can get stronger, to see if they'll be able to achieve their full oral feeds. Or sometimes in an acute situation, we'll see kids after an upper respiratory infection, some kind of viral infection where they need temporary insertion of an NG tube because they are getting fatigued with feeds. So I think that thinking of it like that is totally reasonable and very
So we did
interesting.
it
I like that.
We did
Go
it
ahead, I'm
with
sorry.
one of the ILD child, a child with ILD. And yeah, we did see recurrent desaturation, and the mother was from Andhra, so I didn't know how to. So the counseling part, what the Srinivasan sir is saying, the first phase where we sit with 1 hour, okay, we realize that the child is having abnormal swallow, not just atypical, but abnormal feeding and swallowing physiology. But explaining to her, because again, once she goes back, she's going to give the child the feed and the rehospitalization. So that projectile is going to take a whole new curve. So to stop that, our best approach, myself and pulmonologist who supported in this as well. So we decided that we'll send the child with NG feeds and see how the child is doing. And the child was doing well, and we were able to do a VFSS also because the child was not just surviving but also thriving. So, and at this point, we are actually happy that though the child has a genetic condition and ILD, the child's thriving well. So the child started school, and so yeah, it's interesting. Yeah.
can
No,
I
that's
just
great.
add
And
in
I was just
one
gonna say,
thing?
if you want to see fatigue, if the child is young enough and will tolerate, and the fees, then that's one thing we can try. And then the other thing, there is a protocol that was published, I think, out of the Medical University of South Carolina, where they basically did their video fluoroscopic swallow study at certain intervals. So it wasn't continuously for 2 to 3 minutes, but they would just like do it later in the feed to see if swallowing worsened with fatigue. So that's something, if you're suspecting it and you need to convince the parents or anything like that, or you need to see it to make a decision, that might be a protocol to consider in these particularly little bit different patients.
Also, ma'am, just to compliment here, sometimes changing the consistency, figuring out which consistency is the child developmentally appropriate to have. Sometimes they are feeding a child the consistency of food which he does not have the strength to feed. And that takes very long, fatigues out the kid faster. So, a tie up with a dietitian is very helpful, especially for kids who are just thriving. We tie them up with a nutritionist who, and we comment on the consistency. For example, if a mother is giving their child hand mashed food and the child is taking 1 hour, is drooling the food, is not being able to chew, we move them down the line to thick liquids or mildly thick liquids, and then ask the nutritionist to fortify that. So whatever diet the child is able to take right now, we fortify that. The meal times reduce, the stress reduce, and in the interim, we also move, we keep working on improving the oromotor skills. And then slowly and steadily keep adding textures to it and move it up the HC scale.
Yeah, yeah, thanks. I think the diet modification again. So one question I have for Alicia. So again, what steps did you take for better collaboration with the team members? Because that's something I can see that is a limitation in us. Like I work separately.
I'm very fortunate to be hired by a team of doctors and by UNICEF. So we have a team. I work as a part of the Nutrition Rehab Center run by UNICEF, where we have a pediatrician, a nutritionist, an airway safety ENT doctor, a gastroenterologist, all at our fingertips. And luckily, going other than from my UNICEF work, I am associated with, so it is about building up rapport. So me and at least the airway safety surgeon, we attend to patients together. So even the first consult is done together, where if I'm doing the bedside eval, my doctor is also present with me, and while she's doing the airway safety exam, I'm present. I sometimes also, as time permits, attend surgeries with them to have a better idea of what happens from the medical point of view too. So we have done a couple of OT fees also, OT evaluation, where they can just feed something before they sedate a child if it's permitted, and OT, just all of that. So what I've learned in my 2.5 years with UNICEF is that associating with a pediatrician is of prime importance, because that's where I learned how to plot a child on a growth chart, what's okay, what's not okay. Also with a neonatologist, since we deal with the NICU kids, they help us really understand the growth trajectory of a child. What parameters are to be worried about, what are not to be. So luckily I work in a pediatric hospital, so that helps me with the teamwork. Yeah.
Yeah. Okay. So yeah.
So I think this has been great. I think this whole series has been great. From learning point of view, we all learned a lot as well. Um, I think it's a good point where we are at a good point where I think we should create an interest group of all people who are interested in pediatric swallow as a WhatsApp group, so that we can share cases, learn from each other, and just continue this process which we have started, so that this thing will continue to help each other basically. So I think that will be a good way. I'll get Thiru to lead on that and put everyone together. Thiru.
Thiruji?
Oh, anyway, I'll have a chat with Thiru, but I
Yeah.
think with that we should end the session.
Sorry, Deepak, I'm back.
Yeah. Oh, I was just saying. I know you are watching the cricket match, right?
No, 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 absolutely no, 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 no.
So
I'm.
anyway, I was just saying that we should create a WhatsApp group of people interested
Yeah,
in
yeah, yeah,
pediatrics.
I listened to that. I listened to that. I didn't realize that I was muted, so I was talking also.
Oh, okay.
So
Okay.
anyway, so
Yeah.
anyway, already the swallowing group is there. We
Uh-huh.
need to add whoever is interested in. So anybody can present now and then and put their cases, doubts, and we keep on doing this discussion going on. And this has been a fantastic series. I learned a lot in this 6 months of this course. I'll have to personally thank Dr. Deepak and his team for agreeing to do this in the first place. So I was just simply asking when I was in Denver. So in the night dinner or something like that, I never expected this to be a formal 6 months course, and he suggested that we can do it like a month on month course, so that it will be like a complete course. We can start from the basics till the difficult cases discussion. We can do that. So it went on well, and now we have all the collections as well. So we are going to go edit everything and put it on the website soon. And thank you so much, everyone, for joining in and putting in your thoughts and getting time off to listen to all the experts. And it's been a great experience for all of us. Thank you so much.
Yeah, thank you. Many of the SLPs they've shared that it was very good learning for them. And today's case discussion particularly was, we needed these insights from all of you. Thank you. Thanks to Thiru sir, and thanks to Child Trust, and thanks to Deepak sir and team.
Thank you all. Thank you all.
Thank you. Thank you.
You're
Thank
all
you.
amazing. You're doing great work. Keep on doing the great work you're doing. Lauren, Natalie, thank you.
Thank you.
Thank you.
Thank
Yeah,
you.
no problem.
Thank you.